So we know that the optimal placement of IOL is within the capsular bag, and in case of secondary IOL implantation, the fibrous fusion of the anterior and the posterior capsular leaflets makes them inseparable, and in the bag option is usually not feasible. So the IOL placement actually in the ciliary sulcus is rarely a matter of choice, and it serves only as the most viable alternative. The concept of capture technique was firstly described by Neuhan for placing the haptics in the sulcus and capturing the optic through the anterior rhexis. Gimbel and Debrov then described this technique in the pediatric cataract surgery with the haptics in the capsular bag and optic through the posterior rhexis. However, the capture techniques are mainly used in studies in either primary pediatric cataract surgery or the adult cataract surgery, and very few clinical studies actually looked into the feasibility and the safety of optic capture technique during the pediatric secondary IOL implantation. I'll be showing two techniques to perform the optic capture. This is the first case, and I'm showing you here that this Sommering ring, or this capsular actually remnants or cortical remnants present, they have to be removed prior to the implantation. As Dr. Aman mentioned, the key point in secondary implantation is ensuring a completely free sulcus from synecdoche in order to center the IOL later. This is a very useful technique I learned from my professor, Dr. Hala. You go with the 30 gauge insulin tip connected to viscoelastic, and then you open this ring 360 degrees, then going with the aspiration, aspirate all this cortex all around in order to have this clear capsule for the later sulcus implantation before doing the capture. Also doing then the anterior vitrectomy, and you should open or widen your opening if you have an opening less than 3 millimeters by doing this by the cutter, like aspirating or cutting this fibrous edge all around very carefully in order not to enlarge it more than 5 millimeters. And you can use, as you can see here, the irrigation as a second instrument, because in many cases the pupil is not dilated enough. You ensure that you have a 360 degrees complete rim before implanting your IOL. After you have the 3-piece IOL in the ciliary sulcus, ensuring that it's intact and stable, you just go with the Sinskey hook at one edge of the optic, just pull and press on this edge so it's tucked underneath one edge of the capsule, and then go from the other side, do the same, like pull and press, and you can see here the whole edge of the optic 360 degrees is covered by your edge of the capsular opening. And this is at the conclusion of surgery. You will notice here during washing of the viscoelastic, usually when you have IOL in the sulcus without capture, you find the fluctuation of the IOL in the anterior chamber. Here it's relatively very stable with compartmentalization of both the anterior and posterior segments. We used this technique in the first couple of cases, and then we switched to another actually much easier technique, which we call the snip technique. Here it's real time, it's not edited. You just go in with the curved micro scissors from the main wound and do a snip, actually 2 snips exactly 180 degrees from each other at the 3 and 9 o'clock positions. This is in case you have a small opening that will not permit the capture through this tight fibrous ring. Just by having those 2 snips, you just again, and you have, in case of sulcus implantation, inject the viscoelastic at multiple points in order to inflate the whole sulcus. Unlike when you're injecting within an intact capsular bag, you implant your IOL, and then here you do the capture from the main wound for the inferior edge of the optic. You will see here, you just pull and press at the 6 o'clock position, and automatically both haptics will insinuate themselves within both snips you already done and the superior one from the side port. And you'll have your IOL stable, centered, without any tilt. And again, you will notice the stability when you close your wound and wash the viscoelastic, as you can see here. In contrast, for cases with just sulcus implantation without capture. This is a picture for a case with the capture after SNP technique, just a couple of months after the surgery. We performed UBM of all cases that we've done this technique for, they have negligible IOL tilt and perfect centration for all of the cases. Of course, there are prerequisites. The opening has to be central, complete, and the residual opening should be small enough to capture the optic. So the appropriate size is usually 4 to 5 millimeters. If less, we can enlarge it as shown in those two previous techniques. Of course, we have to use a 3-piece IOL. It offers the advantage of greater IOL stability. All the complications Dr. Aman said of the tilt, the dislocation, and decentration do not happen after this technique. The IOL is closer to the nodal point of the original lens, resulting in better image resolution. It provides a tight seal, which helps maintain stable compartmentalization between the anterior and posterior segments. And technically, it's relatively simple with a short learning curve. And thank you.